Atherosclerotic heart disease Part 1, Angina pectoris. Humayun J. Chaudhary, D.O., M.S., S.M., F.A.C.P., FACOI. Chairman, Department of Medicine and Assistant Dean for Health Policy, New York College of Osteopathic Medicine of NIT. September 20, 2005. September 20, 2005. Case study. A 48-year-old man with a history of tobacco abuse is admitted to the hospital for elective bronchoscopy. On the evening of his admission, he tells the nurse visiting his room that he has been having substernal chest pain for the previous 15 minutes. As the medical resident on call that night, you are contacted first by the nurse. How urgent is this complaint? What do you do? September 20, 2005. Case study. Is there a prior history of ASHD? Does the current chest pain resemble previous episodes of angina pectoris? What is the location, quality and severity of the pain? Is there Levine sign? Is there radiation of the pain? Is there sob? Is there diaphoresis? Is there nausea? What precipitated the pain? Has there been any recent trauma, falls? September 20, 2005. Differential diagnosis, DDX. Acute myocardial infarction, MI. Pain generally persists longer than 30 minutes. More than 50% of deaths occur in first 2 hours. Angina pectoris typically lasts less than 20 minutes. Is there unstable angina? Angina at rest. New onset angina. Worsening angina, crescendo-decrescendo angina, more frequent, more severe, or prolonged. Causes: ASHD, coronary artery spasm, aortic stenosis, thyrotoxicosis, anemia, low diastolic blood pressure. September 20, 2005. Differential diagnosis, DDX. Acute pericarditis. Pain is frequently pleuritic, worsened by recumbency, relieved by sitting up. Causes: infection, post-MI, for example Dressler's syndrome, uremia, malignancy, connective tissue diseases, for example systemic lupus erythematosus. Acute aortic dissection. See excruciatingly severe pain at onset that is tearing in nature. September 20, 2005. Differential diagnosis, DDX. Pulmonary causes. Pulmonary embolism with infarction. Pneumothorax, traumatic. Pneumonia. Gastrointestinal, GI, causes. Gastroesophageal reflux disease, GERD. Esophageal spasm, gastritis, biliary colic. Peptic ulcer disease, PUD, pancreatitis. Musculoskeletal causes. Costochondritis, muscle strain/spasm, rib fractures. September 20, 2005. Unstable angina and intermediate syndrome. Unstable angina represents a constellation of symptoms that usually indicates transient myocardial ischemia. It is an acute dynamic syndrome that is considered intermediate between chronic stable angina and acute MI. 750,000 hospitalizations annually in the U.S. Progresses to acute MI in 15% of cases. Mortality in the first year after diagnosis is 10%. September 20, 2005. Unstable angina. Up to 57% of patients undergo coronary revascularization within a year of presentation. Defined by its clinical presentation in the absence of EKG and cardiac enzyme changes diagnostic of an MI. Prince metals, or variant angina, can present similarly to unstable angina and is due to coronary artery spasm. September 20, 2005. Etiology and pathophysiology of unstable angina. Imbalance in myocardial oxygen supply-demand ratio. Coronary vasoconstriction and platelet aggregation and/or thrombosis are key elements in this supply imbalance. Coronary endothelial plaque ruptures are independent factors. Anatomic location of lesion, Areas of high shear stress are more susceptible. Lipid pool size. Amount of infiltrative macrophages within the plaque. Sympathetic tone. Neurohumoral environment. Impaired fibrinolysis. September 20, 2005. Angiography of a patient with unstable angina. Note the large thrombus formation in the RCA causing the high-grade stenosis and atheromatous ulcer. Rupture of the plaque is highly likely in the tortuous areas of the vessel. September 20, 2005. September 20, 2005. September 20, 2005. September 20, 2005. Atherosclerotic heart disease. 1 million deaths per year among Americans are the result of ASHD. More than 2 out of every 5 deaths in the US are the result of ASHD. Of the current US population, 1 in 4 suffer from some form of ASHD. Prevalence increases markedly with age. September 20, 2005. Reduction in mortality of ASHD deaths. Reduction of modifiable risk factors. Hypertension, better control. Diabetes mellitus, early diagnosis, better control. Hyperlipidemia/dyslipidemia, diet and/or statins. Improvement of socio-economic circumstances. New methods of diagnosis and treatment. Enhanced access to care. September 20, 2005. Once upon a time. In the late 1940s, if a 50-year-old man presented to a U.S. hospital emergency room complaining of chest pain and had EKG changes suggestive of myocardial ischemia or infarction, the following would be offered. Sublingual nitroglycerin to relieve the pain. Supplemental oxygen, as needed for hypoxia. Aspirin for analgesia. Absolute quiet. If the patient survived, he was kept in the hospital for 4 weeks for rest and rehabilitation. September 20, 2005. Vascular injury. Vascular endothelial injury is the critical initiating event in atherogenesis. This injury leads to lipid accumulation, release of various growth factors, migration and proliferation of smooth muscle cells. September 20, 2005. September 20, 2005. September 20, 2005. Study classification regression possible potentially vulnerable. Isolated macrophage foam cells. 2 mainly intracellular lipid accumulation, fatty streak. 3 extracellular lipid pools, intra and extracellular calcium. Potentially vulnerable. 4 core of extracellular lipids, atheroma. V lipid core covered by fibrous cap. Fibroatheroma, Va/mainly calcific, Vb/mainly fibrotic, Vc. Y surface defect, via/hematoma hemorrhage, Vib/thrombus, Vic. September 20, 2005. Histologic studies have characterized the progression of atherosclerotic lesion types. The earliest lesions, from the first decade on, are characterized histologically by isolated foam cells or fatty streaks in the vessel wall. Lesion growth at this stage occurs mainly by lipid accumulation. Intermediate lesions, which may be associated with small extracellular lipid pools, progress to atheroma, which has a core of extracellular lipid. These lesions may be seen starting in the 3rd decade. Starting in the 4th decade, lesions may progress to the fibrous plaque stage, which is characterized by accelerated increases in smooth muscle and collagen. Complicated lesions are characterized by thrombosis, fissure, and hematoma formation. 2. September 20, 2005. Proposed scenario of EDRF and endothelin during ischemic syndromes. September 20, 2005. The vascular endothelium plays an important role in the development of atherosclerosis. A variety of factors, such as lipoproteins, smoking, and turbulent flow, result in endothelial dysfunction. In patients with atherosclerosis, the endothelium is dysfunctional. Production of nitric oxide, which interferes with the production of adhesion molecules, is reduced and degradation of nitric oxide by superoxides is enhanced. A vicious circle results, with further endothelial cell activation and cell attraction and further decrease in nitric oxide. Reduction in vascular relaxation, enhanced platelet aggregation, and increased smooth muscle cell (SMC) proliferation are other results of reduced nitric oxide. 1. This endothelial dysfunction is thought to be the early manifestation of atherosclerosis. September 20, 2005. ASHD risk factors: age, greater than 40 in males, male. Obesity, BMI greater than 30.0. Tobacco smoking. Hypertension. Diabetes mellitus. Family history of premature heart disease. Hyperlipidemia/dyslipidemia. BMI is kg per square meter. September 20, 2005. Approach to patients with ASHD. History. Physical exam. EKG. Cardiac enzymes, CPKMB, AST, LDH, troponin, myoglobin. Admit to the hospital. Definitive treatment with pharmacologic and other interventions. September 20, 2005. Approach to patients with ASHD. Stress test, as tolerated. Gradual exercise stress test. Regular stress test, exercise or pharmacological. Stress echocardiography or pharmacological. Cardiac catheterization, cath-angiography. Percutaneous transluminal coronary angioplasty, PTCA, with stenting. Coronary artery bypass surgery, CABG. September 20, 2005. Sudden cardiac death in ischemic HD. A between 3,400,000 deaths a year. B accounts for 50% of all U.S. cardiac deaths and approximately 25% of natural deaths. C. Cardiac arrest may be the first manifestation in many patients with ASHD, and half of all sudden deaths occur in patients without a prior history of ischemic heart disease. D. Other causes of sudden death. 1. Dilated or hypertrophic cardiomyopathy 10 to 15%. 2. Valvular heart disease 5%. 3. WPW, long QT syndrome, and idiopathic VFib. September 20, 2005. Sudden cardiac death treatment. A. Beta blockers. B. ACE inhibitors. C. Antiarrhythmics, amiodarone. D. Automated implantable cardioverter defibrillator, AICD, the most effective tool at reducing incidence of sudden death. E. Revascularization to decrease ischemia. September 20, 2005. September 20, 2005. Adenosine is thought to act on the coronary vasculature via stimulation of the adenosine A2 receptors on smooth muscle cells, which activates adenolate cyclase to produce cyclic adenosine monophosphate, CAMP, and smooth muscle relaxation. At pharmacological doses, adenosine can cross the endothelium lining and stimulate the receptors on the smooth muscle directly in an endothelium-independent mechanism. Adenosine also acts predominantly on vessels less than 150 microns in diameter. September 20, 2005. Nitroglycerin. A vasodilator that acts directly on smooth muscle through a CGMP mechanism, a non-endothelial dependent vascular response. Because coronary microvessels contain the enzyme needed to convert nitroglycerin into nitric oxide, nitroglycerin creates a dose-related dilation of coronary vessels greater than 200 microns in diameter. September 20, 2005. Coronary stenosis. With coronary stenosis, the microvasculature dilates to compensate. During increased myocardial demand, the capacity of the microvasculature to dilate further is limited. The vessels are already maximally dilated, resulting in myocardial ischemia. September 20, 2005. Evidence suggests that inflammation is a correlate of the development of atherosclerosis and that levels of the inflammatory marker C-reactive protein, CRP, are correlated with the occurrence of cardiovascular complications. In this study, an ultrasensitive immunoassay was used to measure CRP levels in subjects with definite coronary disease, patients with normal coronary angiograms, and healthy control subjects. CRP levels were higher in the group with coronary disease than in those with normal arteriograms or than in healthy controls. Furthermore, within the group of patients with coronary disease, CRP levels were significantly increased in those with recent, less than 2 months from time of study, ME or unstable angina compared with those patients who have stable symptoms. 6. September 20, 2005. Evidence suggests that infectious agents may be associated with coronary atherosclerosis. Several studies have demonstrated serologic and tissue identification of Chlamydia pneumoniae in atherosclerotic coronary arteries. Campbell et al. 7 studied atheromatous coronaries obtained by directional coronary atherectomy, DCA, from 37 patients with angina and ME. They documented the presence of C. pneumoniae by polymerase chain reaction, PCR, testing, by immunocytochemistry, or both in 55% of the patients, with electron microscopy confirmation in 2 samples. Molestein et al. 8 studied coronaries of 90 patients with atherosclerotic coronary artery disease, CAD, and 24 controls, 12 patients without CAD and 12 patients with transplant arteriopathy. 73% of the patients with CAD had C. pneumoniae documented by direct immunofluorescence in their coronaries, compared with 4% of the controls, p less than 0.001. September 20, 2005. Hibernating myocardium. Areas of myocardium supplied by severely stenosed coronary arteries that, over time, develop impaired left ventricular contractility despite the presence of viable myocardium. Clinical importance is that if blood flow is improved to these areas, there is improvement in contractility, which is associated with decreased heart failure symptoms and improved survival. September 20, 2005. Stunned myocardium. Stunned myocardium. Areas of myocardium that develop post-ischemic dysfunction in the absence of, or with, minimal necrosis. Stunning is seen following acute myocardial infarction or repeated episodes of angina. September 20, 2005. Stunned and hibernating myocardium. Both stunned and hibernating myocardium are characterized by severe wall motion abnormalities in the presence of living or viable myocardium. Dysfunctional stunned myocardium is more acute and will regain function over time without intervention. Hibernating myocardium is more chronic. Rigorous restoration of blood flow by revascularization, CABG/PCTA with stenting, is needed in order to restore contractility. September 20, 2005. Bayes' theorem for non-invasive testing. The predictability of a given test depends on the prevalence of the disease in the study population, for example, low likelihood, low probability, high likelihood, high probability. Therefore, routine testing on asymptomatic individuals without significant cardiac risk factors should be avoided because such tests will result in more false positives than true positives. Diagnostic invasive testing is best applied to the group with an intermediate probability of coronary artery disease, such as patients with multiple risk factors and atypical chest pain or patients with typical chest pain but no risk factors. September 20, 2005. Who benefits from diagnostic testing? A patient with a low pretest probability of disease will continue to have a low likelihood of disease regardless of a test. A patient with a high pretest probability of disease will continue to have a high likelihood of disease regardless of a test. Diagnostic testing is most beneficial for those patients with intermediate probability for disease. September 20, 2005. The role of diagnostic testing. Once the diagnosis of ASHD has been made, or the patient has stable anginal symptoms, non-invasive testing remains useful. stratifying patients into high-risk and low-risk groups, monitoring changes in patient status, drug management. September 20, 2005. Nuclear imaging. The value of nuclear perfusion imaging using thallium or sestina B, technetium, has been well established for over the last 20 years. In comparison to exercise treadmill testing, perfusion imaging is more sensitive and provides better localization and identification of multivessel disease. Technically adequate studies are obtained in nearly all patients. September 20, 2005. September 20, 2005. September 20, 2005. Medical management of chronic ischemic heart disease. In the U.S., more than 6 million Americans have a history of ASHD and an estimated 11 million are affected to some degree with coronary plaque formation. September 20, 2005. Silent ischemia. 30 to 40% of patients with myocardial ischemia due to ASHD are asymptomatic, they do not experience ischemic cardiac symptoms. Risk of MI and sudden death is as great as those experiencing symptoms. Angina. Evaluation includes 1. Exercise testing. 2. Ambulatory synth segment monitoring. 3. Other non-invasive studies. Incidence post-infarction is approximately 30%. Treatment is similar to patients with symptoms. September 20, 2005. September 20, 2005. September 20, 2005. Treatment nitrates, dilate vessels and improve flow. Reduce afterload and preload. Preload equals volume, end diastolic volume, EDV. Afterload equals amount of pressure generated to push blood out of the heart. Contractility can be improved by decreasing preload and afterload, but if too vigorous this will decrease contractility. In Laplace's law, tension equals pressure x resistance. As the preload pressure decreases and the radius goes down, wall tension becomes less, and the heart does not need to push as hard. September 20, 2005. Treatment of chronic ischemic ASHD and stable angina pectoris. Beta blockers decrease contractility, therefore decrease myocardial oxygen demand by decreasing wall tension. Calcium channel blockers. Platelet inhibitors. ASA, aspirin, 50 to 500 mg. Clopidogrel for those who are ASA intolerant. High-dose ASA greater than 1000 mg may not result in platelet inhibition. September 20, 2005. September 20, 2005. September 20, 2005. Treatment lipid-lowering agents reduce LDL to less than 100. HDL should be more than 40. TG should be less than 150. Pharmacologic agents, statins, fibrates, resins and niacin. Particle size and density important, large particles and decreased density more favorable. September 20, 2005. Treatment ACE inhibition. ARB, angiotensin receptor blockers, are questionable in terms of their benefit. Folic acid, protective against CAD in patients whose homocysteine levels are elevated. For high homocysteine levels, 1 mg folic acid, if cannot reduce, then add pyridoxine 200 mg daily plus wheat B12 500 mg for 5 days, then 500 mg monthly thereafter. September 20, 2005. Treatment reduction of body weight control diabetes. Stop smoking. Diet low in saturated fats with addition of antioxidants, wheat C and A and flavonoids is recommended. Add fiber to diet, 25 grams. Control BP. Red wine should be considered. Non-alcoholic grape juice products may be beneficial as well. Exercise. September 20, 2005. Coronary angioplasty. Coronary angioplasty with stenting and other catheter-based revascularization techniques play a major therapeutic role in the management of chronic ischemic ASHD. September 20, 2005. By adding a stent to angioplasty, the greatest benefits are seen 100 to 225 days post-procedure, decreasing the need for immediate revascularization. September 20, 2005. Coronary artery stenting. September 20, 2005. September 20, 2005. Angiogram, a SVG that is now stenosed, producing a non-Q wave me with frequent bouts of angina in this 80 years/O male. September 20, 2005. Secondary prevention of ASHD. The secondary prevention of ASHD involves management of cardiovascular risk factors in the patient with established ASHD. Because the patient with established ASHD is at a higher risk of future cardiac events than an individual without established disease, secondary prevention has a greater impact on coronary risk than primary prevention and is more cost-effective. September 20, 2005. 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 Acute coronary syndrome. All acute coronary syndromes, up to and including acute ME, are now thought to share common pathophysiologic mechanisms. A thrombogenic state associated with unstable angina can be detected by various markers of platelet activation and thrombus generation. September 20, 2005. Acute coronary syndrome. Important note: using thrombolytic agents has not been found to benefit patients with unstable angina, this in contrast to its usefulness in acute ME with sane segment elevation on an EKG. September 20, 2005. Variant/Prinzmetal's angina most frequently occurs at a focal site on the coronary artery. Vasospasm occurs at the site of an atheroma/atherosclerotic plaque or within one cm of atheroma. Vasospasm can occur in normal coronary vessels. In this instant, more frequently involves right coronary artery more than left. September 20, 2005. Prinzmetal's angina occurs in younger patients with migraines, Raynaud's phenomenon, and smokers. Cocaine is one of the leading causes of coronary spasm. Endothelial dysfunction. September 20, 2005. Clinical features of variant angina. Younger patients. Pain at rest. Women, men. Pain during night or early morning hours when awakening. Pain that disappears and recurs without warning. Sane elevation with pain, gone when pain-free. Sometimes with pain, have arrhythmias. September 20, 2005. Diagnosis and treatment of variant angina. Ergonovine test during angiogram causes local spasm, causes diffuse luminal narrowing in normal coronary arteries. Local spasm can be reversed by nitrates. Calcium channel blockers are treatment of choice, nifedipine, diltiazem, verapamil. Cigarette smoking and recreational drug use, especially cocaine, should be discontinued. Long-term prognosis is excellent. September 20, 2005. Syndrome X. Chest pain in patients with typical exertional angina, positive stress test and normal coronary angiogram. Microvascular and endothelial dysfunction is present in many patients with syndrome X. More prevalent in women. Treatment: CA channel blockers seem most effective. Nitrates and B blockers are not effective in these patients. Long-term survival is excellent, however. September 20, 2005. 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 September 20, 2005.